Dear friends, in this series of episodes, I am going to discuss methodically what is obesity, what are the complications of obesity, why weight loss is defective or why weight loss is very difficult to achieve, why target weight maintenance is difficult, and what are the ways and means to sustain the weight loss that is obtained, and how physical exercise is more effective in regulation of body weight. So all these I will go slowly one by one. I'll start with what our system is actually made up of, what is our body composition, then go on to discuss about how fat is distributed, what are the different types of fat, what causes accumulation of fat in the abdomen, what is abdominal obesity, why is it dangerous, then how you measure the guts and assess whether the person is obese or not, and what are the causes for obesity nowadays, and how obesity can be controlled, and how to sustain the weight loss that is achieved, and why weight loss maintenance is difficult. All those things will come, say, in 12 to 13 episodes. So in this first episode, I am going to discuss briefly about what our human body is made up of. Otherwise, what is the composition of human body? Human body as a whole, we can divide into three major parts. One is fat, and then fat-free mass, which is mostly present, and then, of course, the minerals and the fluids, right? So fat-free mass includes bone and muscle. So the fitness is equivalent to the fat-free mass. That is how much strengthened your bones and muscles are, determines how fit an individual is. So before going in detail, first we'll start from the basic. As you all know, our body is made up of atoms. The atoms include oxygen, carbon, nitrogen, hydrogen, calcium, etc. in that order. And the atoms together form what is called molecules. The molecules include carbohydrates, lipids, proteins, etc. And the molecules together form what is called the cells. The cells include the adipocytes, the muscle cells, the osteocytes, the blood cells, etc. And these cells together form what is called tissues. The tissues include the bone, the muscle, the blood, the epithelium, etc., etc. And the various tissues form what is called the systems. The systems include the nervous system, the cardiovascular system, respiratory system, excretory system, gastrointestinal system, reproductive system, etc. So then all these systems form the whole human body, and the human body, 60% of which is made up of water, 10% made up of proteins, 15% made up of skeletal mass or bone, and another 15% is made up of the muscle. So all these together form the human body, and this human body can be determined or classified according to the amount of fat and fat-free mass into the ectomorph, mesomorph, and endomorph. The ectomorphs are thin and lean individuals who have very thin muscle built and very less fat, and the skeletal framework also is less. Examples for ectomorphs are the marathon runners. The next group is the mesomorph, who are medium built and they are muscular, well proportionate, with adequate amount of muscle, moderate skeletal framework, and moderate fat. They are proportionately well built, and examples include the tennis players, the professional models, etc. The next group of persons are the endomorph, who are stout and well built, large frame structures. Say, for example, the sumo wrestlers and WWF wrestlers, they have a bigger skeletal mass, they have a bigger bone mass, and their fat content also is more. So thus we can divide the human mankind into three groups: ectomorph, mesomorph, and endomorph. So now we know what our body is made up of. Next episode, I will especially focus on fat and distribution of fats. Thank you. This is second episode where I am going to talk on fat distribution, what are the types of fats and how they are useful to the system, if at all, if there are any uses to the fat. So fat amount differs in men and women. The average percentage of fat is in men is 15 percentage of body weight. Say for example, a young adult male 20 years old weighing 70 kilograms will have approximately 11 kg of fat. Whereas in women, the percentage of fat is more, comparatively more than men. In women, the percentage of body fat is almost 27%. So it is 15% in men and 27% in female. This is an average fat distribution. It varies according to the individual and the age group, of course. So among these 15% in men, 3% of which is formed by essential fat, and the rest 12% is formed by storage fat. Women, the among the 27%, 12% is contributed by essential fat and 15% by storage fat. So from this we see storage fat is almost equivalent in both men and women, whereas it is the essential for fat which is 12% compared to 3%, that is almost 4 times more in women compared to men. So there is more amount of essential fat in women. Now, what is this essential fat? The name itself is self-explanatory. Essential fat is very, very essential to the system or the body, a human body. The essential fat is mostly present in the heart, the lungs, the liver, the kidney, the intestines, the nervous system, the brain, and it is also present in skin and subcutaneous tissue. So these essential fat has some essential functions also. So what are the essential functions of fat? Fat is a storehouse of energy from which fatty acids are released, which is an important source of energy in between food. When we are not taking food, in the interval period, the most important source of energy to the muscle is fatty acid mobilized from adipose tissue. Next, fat is also part of almost all the cell membrane in the body is made up of fat, especially phospholipids and cholesterol, which is a form of fat. Then fat is an integral part of the various steroid hormones, which are called metabolic regulators. Then fat in the subcutaneous tissue acts as an insulator against the external environmental temperature. Then fat in the nervous system acts as an insulator covering the neurons, which mainly functions in conducting the impulses from one part to another. Also, fat that is present in the respiratory airways, which is called surfactant, is very, very essential to maintain the patency of the airway. More than anything else, it is the fat that gives shape to the individual. The shape and contour of the person is determined by the fat that is present. Also, fat in diet makes it more edible or tasty. So thus we understand that essential fat is very, very essential. And in women, apart from essential fat in the systems, there is also another type of fat called sex specific fat, which is specific only to women, which is not much in men. And this sex specific fat is especially present in the pelvic region, in the buttocks and thigh, which act as a storehouse of energy. There is an abundance of energy stored, which is utilized when the female goes in for the reproductive age group. When she bears a child, the fat that is present in the breast mass, which accounts for 4% of body weight, with the help of which all mammals are able to take care of the young ones. Also, the fat that is stored in the buttocks and thigh is a reserve of energy, abundance, a reserve of energy, which is utilized whenever the mother goes in for breastfeeding, or when the woman becomes pregnant. The additional resources that are required during lactation and pregnancy are met by with abundant source of fat that is stored in the pelvic, thigh and buttocks region. Also, this gives the essential shape and contour to the female body. So thus we see there are two types of fat: essential fat and storage fat. Storage fat is same almost in both men and women, whose main function is just storage of energy in the form of fatty acid. essential fat is present in almost all the tissues and does some important functions, as I have mentioned earlier, such as it acts as a part of hormones, a part of a cell membrane, it acts as an insulator, etc., etc. And there is also another type of fat called sex-specific fat, which is present only in women, which is responsible for the essential function of reproduction, which is ultimately required for survival of this mankind. Thank you. I am going to concentrate on abdominal obesity, how fat gets accumulated in the abdominal region. What is truncal obesity? How or what are the sources from where the fat comes and deposits here? So, the storage fat, which is the fat that is present intra-abdominal and also in the truncal region, subcutaneous region, the fat gets mobilized from various sources and gets deposited here. Usually, the source of energy for any person is glucose that is we take it. That is, the carbohydrates that we take in is converted into glucose that is absorbed, and this glucose is the main source of energy. Excess of carbohydrate intake means the glucose is stored as glycogen in tissues, especially the muscle and liver, and which can be mobilized in times of need. But more amount of food that we take in, the excess glucose is converted into triglycerides and it is stored in the abdominal region, which forms the abdominal obesity. So, the first source for accumulation of fat in the form of triglycerides in the abdominal region is the food that we take, which gets digested in the small intestine, absorbed in the small intestine, transported with chylomicrons and stored as triglycerides in the adipocytes which are present in the abdomen. The next source is endogenous fat that is synthesized by the liver, and this fat is transported as lipoproteins in blood, and then by the action of lipoprotein lipase, it is converted into fatty acid and stored in the adipocytes as triglycerides again. The third source is from by a shunt pathway called HMP shunt pathway, by which excess glucose is converted to fatty acids and it is stored in the abdominal region. And the fourth, fat gets accumulated also because of the inhibition of lipolysis, which occurs mainly in the presence of the hormone insulin. And this inhibition of lipolysis due to inhibition of hormone sensitive lipase present in the cells causes accumulation of fat in the form of fatty acids in the abdomen. This is called truncal obesity or abdominal obesity, which is responsible for increased in waist girth as the men age. Especially in men it is more. In women it is more of subcutaneous fat which gets accumulated in the pelvic, thigh and buttocks region, whereas in men it is more of abdominal or truncal obesity, which is due to fat from dietary source, fat from the liver, then also fat from glucose through shunt pathway and also by inhibition of lipolysis. And this fat is more harmful, and this fat is responsible for increase in waist circumference, which is the main indicator of metabolic syndrome, which is a prelude to coronary heart disease, hypertension, diabetes mellitus, etc., etc., all metabolic diseases. So, we will concentrate on truncal obesity, where by aging from 20 to 40, a person gradually increases his waist size by 1 centimeter per year. As natural process, the waist keeps on increases, and this truncal obesity is more harmful than fat that is present in other organs. So, it is the distribution of fat that is more harmful. Why, we will see in the next episode. Thank you. Earlier, we saw what is truncal obesity, what causes accumulation of fat around the abdominal region. Now, in this episode, we'll see why truncal obesity is more harmful than fat distributed in other parts. As I've already emphasized, more than the quantity of fat present in the individual, it is the distribution of fat that is more harmful. So, the more the fat that is accumulated in the abdominal region, especially in men as they age, this which is called truncal obesity, which causes increased in waist circumference, which is a major indicator for metabolic syndrome or major risk factor for metabolic syndrome. This truncal obesity is harmful because the adipocytes present in the abdominal region or the abdominal adipose tissue is releasing a lot of chemicals, and it is anatomically directly linked to the site of metabolism, that is liver, via portal circulation. So whatever chemicals that are released by the adipocytes of truncal obesity or truncal adipose tissue reaches the liver, the site of metabolism, directly. So these chemicals can indirectly influence the metabolism that is taking place in liver, and mostly it is harmful in the sense it induces insulin resistance and thus pave the way for type 2 diabetes mellitus. Now, what are the hormones or substances secreted by the adipocytes that is present in the abdomen? The abdominal fat can be either intra-abdominal or in the subcutaneous region. So, this fat is made up of adipocytes. These adipocytes are filled with triglycerides. These triglycerides are occupy what is called the lipid droplets that is present in these adipocytes. They keep enlarging, and which causes increase in abdominal girth. They release in certain chemicals called adipokines or adipocytokines. So they act as a gland. It's like an endocrine gland which secretes a lot of substances called adipokines. The important adipokines include a hormone called leptin, a hormone called adiponectin, then cytokines such as interleukin 6, interleukin 1, resistin, complement factor, prostaglandins, tumor necrosis factor alpha, etc. So all these chemicals are called adipocytokines. Among these, the leptin and adiponectin are advantageous to the individual, whereas all other hormones, say interleukin 6, interleukin 1, tumor necrosis factor alpha, complement factor, all prostaglandins are all harmful. How? We will see in detail. This hormone leptin that is secreted by the adipocytes of abdomen, they are the hormones that are responsible for satiety. So when a person takes more food, it gets accumulated as triglycerides in the abdominal region. And this excess food intake is regulated by the hormone secreted by the same abdominal fat called leptin, which acts in the center of the brain called arcuate nucleus of hypothalamus and commands that the hypothalamus gives feedback signals to the gut that you stop eating. So this is called satiety hormone. It gives a sense of fulfillment. So this leptin is very, very essential to the system energy homeostasis, to maintain the glucose level, to maintain the insulin action. The next hormone, adiponectin, which is also very, very beneficial. This is also secreted by adipocytes. This adiponectin is responsible for burning the fatty acid in the muscle. So it is called the guardian angel against accumulation of fatty acid, number one. And number two, the adiponectin increases the sensitivity of insulin at the level of muscle and liver. The target organs for insulin are liver and muscle mainly. The adiponectin increases the sensitivity of insulin at these target organs, liver and muscle. So adiponectin action is beneficial. Adiponectin enhances the action of insulin, to be precise. Adiponectin also has an anti-atherogenic effect. It prevents accumulation of fat in the intima of blood vessels and prevents atherosclerosis. Thus, you see, leptin is responsible for controlling the food intake, or it is responsible for satiety. Adiponectin is responsible for enhanced action of insulin at the level of muscle and liver. It is also responsible for burning the fatty acid, prevents accumulation of fatty acid. Whereas the other adipocytokines, interleukin 6, interleukin 1, the tumor necrosis factor alpha. So all these adipocytokines, which are released directly into the portal circulation, they reach the liver and they enhance the insulin resistance at the level of liver and muscle, and thus make the individual prone for type 2 diabetes mellitus. Also, the prostaglandins, the complement factors that are released, the resistin, they can cause endothelial damage because of their action in the endothelium. The adipocytokines make the individual prone for atherosclerosis. So, the first two hormones are anti-atherogenic, but the latter four adipocytokines, tumor necrosis factor alpha, interleukin 1, interleukin 6, complement factors, prostaglandins, they are inflammatory mediators and they are atherogenic. And thus, we are worried more about truncal obesity than the percentage of fat distributed elsewhere because of its close proximity to the liver and because they influence exactly on the site of metabolism because of their action on the action of insulin at the level of target organs, liver and muscle, which is of the damage that caused to the endothelium. Thank you. So, in this episode, we will see how our system regulates hunger, satiety, and what is the main reason for obesity physiologically. The main organ that is concerned with regulation of satiety and hunger is a part in brain called hypothalamus. Especially the lateral hypothalamus is responsible for regulation of hunger, and the ventromedial hypothalamus is responsible for regulation of satiety, that is the feeling of fullness. And this hypothalamus receives both hormonal and neural signals from the periphery, in the sense from the gastrointestinal tract, and these hormones will cause either hunger or satiety. The hormone that mainly causes hunger, which is called orexigenic hormone, is ghrelin, which is secreted by the parietal cells of the stomach. The stomach mucosa, there is a group of cells called parietal cells. They secrete this hormone ghrelin. This ghrelin, which is released, acts on the lateral hypothalamus and it induces hunger, the urge to eat. Then, as the person takes food, especially the food that is rich in protein and fat, if it reaches the intestine as partially digested food products after getting digested by the saliva and gastric juice partially, the partially digested food and made up of protein and fat mostly, partially digested protein, if it enters the small intestine, it stimulates the mucosa of small intestine to release certain hormones, namely GLP-1 or glucagon-like peptide and GIP, gastric inhibitory polypeptide, also a hormone called cholecystokinin, and also a hormone called oxyntomodulin, which is released in the large intestine, and another hormone called neuropeptide Y. So, these hormones CCK, cholecystokinin, GLP-1, glucagon-like peptide, GIP, gastric inhibitory polypeptide, and neuropeptide Y, they are released when mostly food rich in protein and fat reaches the small intestine. These hormones that are released will act on ventromedial nucleus of hypothalamus through specific receptors mediated by arcuate nucleus, and they cause a feeling of satiety. They further prevent intake of food. The system says enough is enough, don't take much food, stop with that. So, that is, they are called satiety hormones. So, apart from this, the distension of food reaching the small intestine stimulates the vagus nerve, and the vagus nerve also acts in the ventromedial nucleus of hypothalamus, and this also will induce satiety or feeling of fullness of the stomach. So, we stop further intake, and thus we are protected from excess accumulation of fuel in the form of fatty acid in the adipose tissue, otherwise we are protected from obesity. So, also this GLP-1 and GIP, apart from acting on the hypothalamus, they also act on the beta cells of islets of Langerhans in pancreas, which is an endocrine part of pancreas, to release an important hormone called insulin. And this hormone insulin takes care of the food that is taken, which is converted into glucose, and this glucose is dealt by this hormone insulin. The insulin makes this glucose enter into the cell, increases the cell membrane permeability for glucose, and is utilized as a source of energy by a process called glycolysis. The excess energy being stored as glycogen, and much excess energy is stored as triglyceride in the adipose tissue. So thus the GLP-1 and GIP not only stops further food intake by acting on the hypothalamus, also deals with the end product of the food that we take, mostly glucose, by promoting the release of insulin by an effect called incretin effect. And this insulin takes care of the glucose that is assimilated by the digestion of carbohydrate in the small intestine. Next, the another hormone that causes satiety is the leptin, which I have already discussed, released by the adipocytes that is present in the abdomen. The abdominal fat acts as a gland. It releases a lot of hormones which I discussed, the most important hormone being leptin. And this leptin is advantageous. More leptin is released, more the amount of adipocytes. So a person becomes fatter, he starts releasing a lot of leptin. And this leptin acts on the hypothalamus at the level of ventromedial nucleus, and ventromedial hypothalamus stops further in food intake, which is called satiety center. So leptin is very advantageous in regulating the food intake. So what happens in obesity? In obesity, I have already told you the amount of leptin secreted is more because the amount of the number of adipocytes are more. Though the amount of leptin secreted is more, the person becomes obese further because there occurs a phenomenon called leptin resistance. The more leptin that is secreted after a certain level is no longer beneficial in controlling the appetite. The cells, the receptors in the hypothalamus become resistant to the action of leptin. It may be attributed to the fatty acids that are released, which go to the hypothalamus, and they prevent the leptin from acting. So leptin receptor resistance is the first cause for obesity, or leptin being ineffective in regulating the food intake. The second major cause for obesity, physiological cause for obesity, is attributed to a defective leptin hormone. The more the adipocytes, the leptin released by the adipocytes in a person who is genetically susceptible to obesity. The gene is called OB gene or obesity gene. In such individuals, the leptin released by their adipocytes itself is defective. So either there is a defect in the leptin hormone that is released, or defect in the receptor in which leptin acts, which is called leptin resistance. So both these contribute to obesity, and the leptin, though the content is more, quality is poor, and they cannot act because of the receptor defect, and it is attributed to fatty acid level in the brain also. Then from this, I would like to stress one more point before concluding. More than the type of food that you take, the quality of food that you take is more important, because more the protein in your diet, and more the partially digested protein that reaches the small intestine, more is the release of these advantageous hormones GLP-1 and GIP, which is helpful in controlling the appetite. It causes satiety. So that is why we emphasize a protein-rich, fat, moderate fat diet and less carbohydrate diet, because a protein-rich diet releases, stimulates the release of GLP-1 and GIP, which is helpful in regulating satiety, and thus helpful in regulating the weight. Thank you. In this episode, I am going to mainly concentrate why obesity is more prevalent nowadays. As you all know, the incidence of obesity has almost tripled worldwide. It was 14% in the developed countries around 1980s, and now it has almost 3 times more, 42% in the developed countries like USA. Obesity is more common, especially in childhood. Childhood obesity is more common. Why we are more concerned about childhood obesity? A child which is obese around 7 to 11 years, has a 33% risk of becoming obese as he or she grows as an adult. So, childhood obesity is the time when we should concentrate. And why this obesity is more common nowadays? For that, we will know, we'll go to evolution, but go back to evolution. Earlier, we had a hunter-gatherer lifestyle where we have to hunt for our food. We were nomads moving from place to place, and we had food was very scarce at that time. We had food say once a day or twice a day when food is available. Rest of the time we were moving around in search of food. So food was rare and we moved more. So when food was available, the food that we take, the excess energy is stored in triglycerides as glycogen or stored in adipose tissue, as glycogen or triglyceride, and this food is mobilized when required. So when food availability was less, when we were moving more, there was no problem of obesity at all. So when we had excess food, we stored it in the adipose tissue. When food was not available, when we are moving around, from the adipose tissue, the triglycerides are converted into fatty acid, and these fatty acids are utilized as a source of energy. And we were moving more, so there is no chance of excess accumulation of triglycerides in the adipose tissue. Whereas nowadays, the environment has changed. There is abundance everywhere. Whatever is required now, whatever is available at a phone call. So we have everything around us. So there is a problem of plenty, and added to that, our life has become more convenient. We are more sedentary now. We are reluctant to move. So both problems get compounded. Availability is more, but utilization is less. That is why the excess energy is being stored and we have a tendency to become obese. This is called environmental influence. So the very environment influences us to be obese. Why? Food is available everywhere. In every street we get food. Every street we have a bakery, a parotta stall, at a clinic and a medical shop. So we eat parotta, go to the doctor immediately the next dose, right? So food is available. And what type of food? High calorie, energy rich foods. Whatever we eat are king size now. We go to a theater, in the interval, what we take? We take a bucket of popcorn. Earlier, popcorn was only just a small packet, for 5 rupees or 10 rupees. But we get unlimited bucket of popcorn for around 600 rupees, and we drink this much Coke to quench the thirst. Both are harmful, and even that bucket can be replaced. So how much we are taking? We are taking a bucket of popcorn and this much Coke, and all these beverages have higher added sugars. The added sugars permitted per day is only 40 grams, but a small can of Pepsi alone contains this 36 grams of sugar, one small can. But what we take is this much, which is almost twice or thrice. So all these are added sugar, which adds on to the problem of energy available. Next, of course, we move very less nowadays. We don't go for preparation of food at all. Food is available ready-made, packaged food, which with high salt content and preservatives, which are very, very harmful. So we don't undergo this process of preparation of food, number one. And now, next step has evolved. We no longer go to buy the food. We just give a phone call, food is there at our doorstep. So the mobility to get the food also has stopped. So food is at doorstep. What type of food? High calorie, energy rich food, beverages with a very high added sugars. Then we have preserved packed foods, say Lay's, Kurkuri, which has a high salt content and fat. All sorts of additives, preservatives in them, which compounds and adds on to the problem. So we take more, consume more, and we are not satisfied with small portions anymore. We always have more. Number one. Number two, we started moving lesser. We don't walk to the office nowadays. There are no playgrounds in the schools now. We don't go by bus, we have our own vehicles, we don't climb up, we use the lift, we don't move from desk to talk to people, we use intercoms, and with the cell phone and video games, we seldom go out. So we don't move and we have a lot of food. So this is called behavioral strategies. By behavior, we stopped moving. So first there is an environmental influence which tempts us to have more than what is required, and we have a behavioral strategy where we move less, we are more brainy now, we sit and work more rather than doing physical work. Then third, the physiological influences. The influence from the brain, from the hypothalamus, now is defective. As I've already told, leptin hormone is defective, there is leptin resistance. So all these three contribute to obesity now: environmental influence, behavioral strategy, and the physiological influences. So all these three are favorable for the tendency for a person to become obese, which is even more common in a genetically prone individual who has this OB gene, which secretes defective leptin from the adipocytes. That is why the incidence of obesity has tripled from 14% to 42%. Thank you, friends. In this episode, we are going to know how to evaluate clinically and diagnose a person to be obese. Clinically, when a person comes to the clinic, how to categorize him as an obese, how to say whether he is obese or not, just by three physical measurements. Number one, it is called body mass index. Number two is waist hip ratio, and number three is skin fold thickness. By doing these three clinical parameters, by assessing these three clinical parameters, we can come to a conclusion whether the person is obese or not. All three are simple physical measurements. You don't need any advanced equipments to measure this. Anybody can do it even in their home. Now, what is body mass index? It is the ratio between weight in kilograms divided by height in meter square. So, a body mass index between it comes as a decimal. A body mass index, say less than 18.5, a person is categorized as underweight. A body mass index between 18.5 to 24.9, a person is categorized as normal weight. A body mass index from 25 to 29.9, a person is categorized as overweight. A body mass index more than or equal to 30 is categorized as obese. And obese also can be graded as grade 1, grade 2, grade 3 obesity. If the person's body mass index is more than or equal to 40, is categorized as morbid obesity or very severe obesity. Okay, so body mass index, I'll just to say again, it is a ratio between weight in kgs divided by height in meter square, and normal BMI is between 18.5 to 24.9, and a person is diagnosed as obese if his body mass index is more than or equal to 30. Next, waist hip ratio. It is the ratio between the waist circumference and the hip circumference. Now, we will first know what is waist circumference. Waist circumference is a circumference measured by an inch tape in or centimeters. The narrowest part of waist, usually just above the umbilicus, at the midpoint between the lowermost part of rib cage and uppermost part of iliac crest. You take an inch tape, keep it snugly, and then ask the person to take 2 to 3 breaths, then ask him to stand straight with feet apart, and the measurement should be done while exhaling. He should not inhale, tuck in and try to reduce the circumference. He should exhale, and while exhaling, you should measure and make the person used to the procedure by making him taking a deep breath 3 or 4 times, and never allow the subject to look down. When he look down while measuring, while he looks down, he tries to contract the abdominal wall muscles and just he may mask the circumference. So make him relaxed, stand straight with feet apart, measure the narrowest part of waist after exhaling, and ask the subject to look ahead, not look down. Then normal waist circumference is less than or equal to 90 centimeter in male and less than or equal to 82 centimeter in women. This is the ideal waist circumference any individual should try to maintain. More than this, the person has got a risk factor to develop metabolic syndrome. The next, hip circumference. It is the circumference measured in the widest part of buttocks, where the subject is asked to stand with the feet together and look ahead. Take the inch tape, measure around the widest part of buttocks. Take this ratio. The waist hip ratio should be usually, it is desirable to maintain less than 0.9 for men and 0.8 for women. Any waist hip ratio more than 1 for men and more than 0.9 for women is considered a high risk factor for metabolic syndrome, coronary heart disease, type 2 diabetes mellitus, etc., etc. Third is the skin fold thickness, which is measured using a Vernon caliper, because as I've already told, most of the storage fat, especially in women, is stored in the subcutaneous tissue. So you measure the skin girth using this caliper. The major sites that are used for measurement are the chest, abdomen and thigh in the case of men, and in the case of women it is triceps, suprailiac region and the thigh. You measure. Usual skin fold thickness is less than 20 millimeters in the case of men, the triceps skin fold thickness I am saying, and in case of women it is less than 30 millimeters. So this skin fold thickness also helps to assess how much subcutaneous fat is deposited in the individual and thus assess whether the person is obese. So to repeat, 3 parameters which can be assessed easily either at clinic or home using just a weighing machine and an inch tape. One is BMI, number 2 is waist hip ratio, and number 3 the skin fold thickness. By assessing all 3, you can categorize whether the person is underweight, normal weight or overweight or obese category. Thank you, friends. Friends, in this episode, we will concentrate on why obesity is problematic nowadays. Earlier, when we were young, our mother used to feed us well and make the child look plumpier. So, plumpiness was related to prosperity and healthy. Plumpier the child, the mother thinks that the child is healthy, but it is no longer considered so. Plumpier the child becomes more prone for obesity later. If the person is obese, especially after 40 years, he is likely to face a lot of problems. And what are the problems faced by an obese person? That is what I am going to concentrate. So the problem starts here. The person's self-confidence goes. There is poor self-esteem. He is not able to mingle freely with others. He has a distorted body image of himself. He doesn't have the confidence. He thinks that he is obese and he is not looking good in front of others, so he cannot communicate properly. Also, his intellectual behavior, his professional achievement, everything deteriorates because of the obesity. So it is more or psychosomatic disorder. It causes a lot of psychological disturbance. Then it also causes systematic disturbance. It affects almost all the systems in the body. Primarily, it affects the cardiorespiratory system. In the respiratory system, because of obesity, excess fat the respiratory muscles and the diaphragm becomes ineffective. The person doesn't have a free flow of air, he breathes with difficulty, and so he develops what is called exertional dyspnea. Even if he climbs the stairs for one floor, he develops dyspnea because his respiratory muscles are not working properly, not efficient enough. Then an obese person also suffers from another problem called sleep apnea, wherein in between sleep, when he falls into deep sleep, he can no longer breathe freely. The upper airway muscles tone decreases drastically, so there is a choking for breath. He has to get up from sleep, go to the window, take 2-3 wisps of fresh air, then come back and continue to sleep. This especially occurs when the person moves on from non-REM to REM sleep. And this REM sleep comes 3 to 4 episodes per sleep period. So every night, if a person develops the sleep apnea for 3 to 4 times, then he has quality of sleep drastically falls down. He doesn't feel fresh in the morning. So next day productivity falls down, and he has excessive sleepiness in daytime. That is why he sleeps even when the car waits and signals for a few seconds. Then after getting the blaring from the back, he starts moving. So the sleep apnea is common in obese individuals. And also bronchial asthma is very, very common. Narrowed airways, when the climate also drastically falls, bronchospasm secretions add on to the breathing difficulty. So asthma or obstructive pulmonary disorder are common in obese person. Then in cardiovascular system, obese people are more prone for elevated blood pressure. They are more prone for endothelial damage because of the cytokines released from abdominal adipocytes. I have already told you, adipocytokines cause endothelial damage, make the individual prone for atherosclerosis, and there is also a tendency for hypercoagulability. The coagulation disorders are more. All these makes the person prone for coronary heart disease. So the quality of life, the very life expectancy deteriorates in the obese person. Suppose the average lifespan in an adult male is 70 years, in an obese it drops to 64 or 65 years. Then in the abdomen, the gastrointestinal tract, obese persons are prone for this disorder called gastroesophageal reflux disorder, where there is reflux of gastric juice into the esophagus, especially at night when he falls to bed or when he falls asleep after having a full meals late at night. Because of the excess fat, the diaphragm muscle is weak, so doesn't act as a valve and prevent the reflux of stomach content into the esophagus. The stomach contents move to the esophagus. They suffer from what is called gastric burn at night, otherwise gastroesophageal reflux disorder. Also, obese persons are more prone to develop fatty liver. Accumulation of fat in the liver causes a major problem nowadays, even in vegetarians, even in non-drinkers. It is called non-alcoholic fatty liver disease, which predisposes the individual to cirrhosis later on. And the individual is also more prone for developing gallstones, cholecystitis thereof. So then it also affects the endocrine system. The obese person, because of the adipocytokines that are released reaching the liver, are more prone for insulin resistance, and insulin resistance causes type 2 diabetes mellitus. And obese people also suffer from menstrual irregularities, polycystic ovarian disease, infertility is common in obese women, and all sorts of endocrine disorders, hypothyroidism, everything is associated, either cause obesity or associated with obesity. Either hypothyroidism can lead on to obesity, or obesity can cause polycystic ovarian disease, menstrual irregularities, infertility, etc., etc. Then obesity also affects the kidney. It makes the individual prone for glomerulosclerosis, renal carcinoma. Cancer is very, very common in obese individuals. Obesity and cancer. Obesity is an important risk factor for cancer apart from other risk factors. Obese individuals are prone for CA breast, CA endometrium, renal cancer, colorectal cancer. Very, very common in obese individuals. So when you all know cancer and life expectancy are interrelated. The quality of life goes, life expectancy falls down drastically. Also, obese individuals are prone for musculoskeletal disorders, more the osteoarthritis of knee because of the weight they are not able to bear, the degeneration of knee add on to the weight and loss of hormones in old age menopausal women. The obesity contributes further to arthritic changes, degeneration. They are also more prone for ankle sprains, flat feet, they are more prone for backache. All these decreases the quality of life, especially in a women more than 45-year-old. When when the woman reaches, attains menopause, she also develops osteoarthritis, then her quality of life drops further. So, just we see obesity affects, causes all systemic disorders, endocrine disturbance, psychosocial disturbance. So, correction of obesity is very, very essential to improve the quality of life, to improve the life expectancy of the patient. Thank you. In this episode, we will concentrate why obesity is linked to metabolic disease, why excess adipose tissue causes metabolic syndrome, or how excess adipose tissue or excess triglycerides in the adipose tissue causes metabolic syndrome. As you all know, the excess of fuel that we take is first converted to glycogen. It is stored in the muscle and liver. Then the excess food that we take is converted into triglycerides and stored in the adipocytes as triacylglycerol. It is stored as triacylglycerol because it is water repellent, and the amount of energy, more energy can be stored in a lesser space. Instead, if it is stored as glycogen, it has to be stored along with water, which will lead to increase in almost 60% of the weight. Say, for example, it itself will require 60 kilograms. So, imagine the rise. The normal amount of fat in a 70 kg adult male is only 11 kilograms. If the fat is stored as triglycerides, then the amount of space required is less. If the same excess energy is stored as glycogen instead of triglycerides or triacylglycerol, the space required is more because it has to be stored along with water. So, nature has made this adaptation to store excess energy as the concentrated form called triglyceride, which yields more amount, almost twice or thrice the amount of energy derived from proteins or carbohydrate. 9 grams instead of, 9 calories per gram instead of 4 calories per gram in this case of protein or carbohydrate. So, it is an energy dense storage with less space. And this triglyceride accumulation in the adipocytes occurs in what is called unilocular fat depots. They are similar to the organelles in any other cell, and more the triacylglycerol that is stored, it keeps enlarging, and the cell becomes engulfed with fat, and after a physiological limit, it even destroys the fat cell, and the excess fat get deposited in some other cells, namely the liver or muscle, which are called unprofessional cells, which are not professionally capable of storing fatty acid as adipocytes. So, fat ideally has to be stored as triacylglycerol in adipocytes. If it is excessive, it even causes destruction of these adipocytes, and this after destruction, the fat that is released or the fatty acid that comes over and above what is stored in the adipocytes gets stored in non-professional cells called liver and muscle, and that is the problem for type 2 diabetes or metabolic disease. Reason number one hypothesis states that in the adipose tissue of obese people, there are more amount of macrophages because there is more inflammatory reaction in the adipocytes, and more macrophages are present to deal or remove the excess cell debris that occurs due to a destroyed adipocyte due to excess accumulation of fat. So, this inflammatory reaction makes the individual prone for type 2 diabetes mellitus or metabolic disease. Then number 2, the excess fat I have already told you, apart from being stored in adipose tissue, adipocyte saturation level, if it reaches, gets stored in unprofessional cells like liver and muscle, and these unprofessional cell storage of fatty acid causes defective insulin receptors in them, and insulin cannot act. As you all know, the target organ for insulin for its ideal metabolic activity is the liver and muscle, where the insulin receptors are abundant. So once fatty acid gets stored in these non-professional cells present in liver and muscle, they become insulin resistant. Insulin cannot act, though there is hyperinsulinemia because of excess energy available, the insulin becomes useless. So these individuals become prone for the metabolic disease. So these are the two hypotheses that states or suggests why metabolic disease is common in obese. Number 1, the inflammatory reaction mediated by adipocyte lysis and that causing accumulation of macrophages in the adipocytes. Number 2, the release of adipocytokines, and number 3, the presence of excess lipid in the non-professional cells or fatty acid storage in non-professional cells like liver and muscle makes the individual insulin resistant. Thank you. In this episode, I am going to talk about the solution to this obesity. So far, we have discussed what causes obesity, what is truncal obesity, why truncal obesity or distribution of fat is more important than the total amount of fat. We discussed what are the problems faced by an obese individual and why metabolic disease is more common in obese. Now, how to counter this problem of obesity? What are the steps to maintain the weight loss, how to decrease the weight loss, and how to overcome this burden of obesity? So we can regulate our body weight by 3 approaches. Number 1, the first approach is we can either decrease the amount of daily food intake. We should not drastically cut short our food so that it interferes with our day-to-day routine, it affects us psychologically. We should go slowly and steadily. So first aim is to decrease the calorie load, and we should try to decrease it by 500 kilocalories per day. Say for example, an average adult male takes 2800 kilocalories per day. He should aim to reduce it to 2300 to 2400 kilocalories per day. There is no point in trying to reduce it to say 1500 or 1400, which is practically very difficult to sustain over a long period. You should aim for a calorie loss or calorie restriction per day, which is practically possible, which doesn't interfere with his day-to-day routine, which also makes him continue with the habit of decreased calorie over a long period of time, because it is the sustained slow weight loss which is aimed at reducing 10% of body weight is in the long run feasible one. More drastically you reduce your weight, more sooner you get it back. Why I will be discussing it in my next episode. So aim for a slow and sustained calorie loss of approximately 400 to 500 kilocalories per day. This you easily can achieve by reducing just one idli per day, or reducing the intake of one banana per day, or reducing the amount of sugar that you consume along with the tea or coffee that you take daily, or almost stopping this packed foods like Lay's, Kurkure, or stopping the beverages rich in added sugars like Pepsi, Cola, etc. So these simple habit modulations can achieve this small calorie loss of 500 kilocalories per day, and this you can sustain over a long period of time where weight loss can be maintained, number one. Second, we should improve the quality of life. More you should become mobile. You start moving more, start expending the energy that you take, because obesity is due to the excess energy that we take, which gets accumulated. So which is equal to the total amount of energy that we take minus total amount of energy that we expend. The total amount of energy expended is broadly comes under three categories. Majority 60 to 65% of energy that we consume is used to maintain the basal metabolic rate. Number two, the energy that is used to as what is called thermic energy for food, which is used to consume the food that we take. That is called thermic energy expenditure for food, which is almost 10% of the food that we take is utilized for that, and only physical activity consumes 10 to 15%. We can either decrease the physical activity or increase the physical activity to alter that 15% of energy expenditure for physical activity to either 5% or 25%. So our aim initially is to increase the energy expended for physical activity, say from 15% to 20 or 25%, which can be easily achieved by using the stairs when you go to the office, getting down one stop before the office and walking to the office, moving from place to place. Try to use bicycles instead of two-wheelers, walking to the shops. So just simple lifestyle modifications, instead of dropping your child, walking your child, walk with your child, walk with your pet dog, arrange for family get-togethers as a walking program, arrange for social gatherings which welcome walking, say for example going on a pilgrimage by walk. So simple lifestyle modification can increase the excess energy. Then third, later on, once you start getting the benefits of decreased calorie intake and increased physical activity, then start a structured exercise program and also watch your diet meticulously. So the classic approach will be decrease the calorie intake and also increase the energy expenditure by adopting a healthy structured exercise program, by adopting an effective meal plan, both of which can get you a sustained long-standing weight loss, which you aim at the rate of less than 1 kilogram per week. You will try to reduce 1 kilogram per week. That should be your ideal goal. That is 10% of body weight in a month, which can be sustained over a period of time. More drastic weight loss means the weight regains sooner. Thank you. In this episode, I am going to discuss why sustaining the weight loss achieved is difficult. The weight loss over initial period of time is easier, but to maintain the weight loss achieved is very, very difficult. What is the reason for this? For that, we'll just go on to the basic of obesity. What makes a person obese at a cellular level? At cellular level, in the adipocytes, two changes take place. One is increase in the size of the adipose tissue or adipocyte, and number two, increase in the number of adipocytes. Increased size is called hypertrophy of adipocytes. That what happens initially. A person who has an increase, moderate intake of food, first has an increase in size of the cell, adipocytes, from 0.6 microgram to 0.9 microgram, maximum of 1 microgram. This is due to accumulation of fatty acid in the lipid droplets that is present in the adipocytes, and because of which the size of the adipocyte keeps on increasing from 0.6 to 0.9 grams. Once it reaches a saturation level, then it can no longer increase in size. Then what happens? The adipocyte number starts increasing. When the person engages in further increased intake of food, the number of adipocytes now increases, say, from 25 billions to a maximum of, say, 75 billions. That's where the person becomes morbidly obese. Very severe obesity occurs because of the increase in number. Till moderate obesity, only the size increases. In severe obesity, the number also increases, adding on to the increase in the size of the cell. So, such a person, if he starts losing weight because of the weight loss program he undergoes, either due to decreased intake of food or increased physical activity, what happens is, in such person, only the size comes back to normal. The size will reduce from 0.9 microgram to original size of 0.6 or even lesser up to 0.3, 0.2 micrograms. But the number of cell never comes back to normal. The hyperplastic cell, the divided cell remains divided. The increased number of cells remains so. So, the adipocytes remain 75 billions. Only the size decreases from 0.9 to 0.6 or 0.3 micrograms. So, there is a tendency to regain the weight again. The divided cell remains, the higher the number of cell, more easily the size can increase back to 0.9 or 1 microgram, and the person has a tendency to get back his original weight. That is why sustenance of weight loss is very, very difficult. Thank you. In this episode, again I am going to discuss the second reason for the difficulty in maintaining the weight loss. Why sustenance of weight loss is difficult? In the earlier episode, I have told the hyperplastic cell doesn't revert back to its original number. The number remains the same. So, the tendency to increase the size is more. So, difficulty in maintaining the weight loss. Here I am going to emphasize on another theory which is called set point theory. An obese person has a set point which is called lipostat theory, which is regulated by the arcuate nucleus of hypothalamus. This arcuate nucleus of hypothalamus has a set point for any individual, especially obese individual. If the point sets that a person, say, 80 kilograms, the hypothalamus regulates the intake and expenditure in such a way, in coordination with the leptin hormone secreted by the adipocytes, the intake is regulated, expenditure also is regulated, and his weight is almost constant around 80 kilograms. Say, for example, he indulges in a weight loss program, he starts losing weight. Once his weight reduces from 80 to 75 kilograms, then the resting metabolic rate also decreases accordingly. Add on to the weight loss and the decreased resting metabolic rate, there is also an increased amount of the hormone lipoprotein lipase. This lipoprotein lipase is responsible for increased fatty acid accumulation in the adipocytes. So, an obese person has a set point of 80 kilogram, and if that set point, which is determined by hypothalamus, decreases to 75, it compensates by decreasing the resting metabolic rate, it compensates by increasing the lipoprotein lipase enzyme. Both this will try to correct and bring back the weight from 75 kilograms to 80 kilograms again. So, this set point theory prevents drastic changes in weight of an individual unless otherwise he strives persistently over a long period by increasing his or her physical activity. By increasing the physical activity, first slowly, methodically, and then persevering with that, starting with say short moderate exercise for 30 minutes, increasing it to 60 minutes, and then increasing the intensity. Gradually there is a loss of adipose tissue, build of muscular tissue, both try to correct this set point. The set point itself goes lower, and the hypothalamus doesn't try to correct the previous set point. Also, because of increased muscle bulk, the resting metabolic rate remains elevated, doesn't fall. All these contributes to a sustained weight loss, which is the aim of any obese person. So the key is increased, sustained, intense physical activity, which can lower the set point of hypothalamus. Thank you. In this episode, I am going to concentrate why or how initial weight loss is easier in an obese person. Say an obese person is going in for a weight loss program, the first 2 weeks he will have a drastic weight loss. Whereas over a period of time, the same diet regimen if he follows, same exercise program if he follows, in spite of that, the weight loss is not as drastic as initial. Initial periods, the weight loss is more. Say he decreases his weight from 80 to 75 kilogram easily. From 75 to 70, it is very, very difficult over a period. Why? Or why the initial weight loss is easier? Initial weight loss is easier because initial 1 or 2 weeks, when a person goes in for a weight loss program, he loses more of glycogen that is stored in the muscle, liver and adipose tissue rather than the fat. The amount of water loss along with the glycogen is also more, because glycogen is lesser, denser and doesn't accumulate much of energy like fatty acid. So more glycogen is lost for lesser calorie loss, plus the amount of water lost also is more. So say in first or second week of a weight loss program, the person loses 70% of his body water. You all know 60% of composition of body is made up of water. So when he loses water initially more, then the weight loss is drastic. Only he loses 20% of fat and 5% of protein. So mostly it is the water loss and glycogen loss initial periods 1 to 2 weeks. So the weight loss is more in the first or second week of a weight loss program. Then he goes in for third week. He sustains the same diet and same exercise program. Then he starts losing fat. Then it becomes 70% fat, 20% water and 10% protein. Then by the third week, he loses almost all the water that he has, which can be lost, except water that is must. Then he goes in for third to fourth week of weight loss program. Then he starts losing fat. So he starts losing fat only after fourth week of weight loss program, where the fat contribution is 85% of weight loss and 15% is protein contribution to the weight loss program. So the initial rapidity of weight loss cannot be targeted in the third or fourth week, where the weight loss is lesser, because fat is concentrated form of energy and fat doesn't go along with water loss, whereas along with glycogen water also is lost, but along with fat loss water is not lost, water is lost already. That is why the initial benefits are more, and it is encouraging to a person who is going in for a weight loss program, but he should not become disheartened later on. When the weight loss percentage is less, he should increase his physical activity, he should be more intense, and his aim should be to improve the muscle mass and thus get more calorie loss because of his increased basal metabolic rate thereof. That is why a persistent, intense physical effect is the key for a good weight loss program. Thank you, friends. In this episode, I am going to give an example how the alteration in diet pattern and an increased physical activity alters the calorie deficit, or how it helps in weight loss. Say, for example, we aim for a calorie deficit of 3,500 kilocalories per week. Calorie deficit is the difference between the amount of energy intake minus energy expenditure. So, we can achieve a calorie loss of 3,500 kilocalories either by decreasing the intake or increasing the energy expenditure by doing an exercise program. 3,500 calories is equal to 0.45 kg of fat or half kg weight. So, our aim is to go slow, say at the rate of half kg per week. We want to reduce our weight by half kilogram per week. That is the ideal goal for any person. A sustained weight loss can be achieved. How to achieve this? For that, we need a calorie deficit of 3,500 kilocalories. How to achieve this? We can achieve it by going stepwise. Number one, first we will try to achieve it by decreasing the amount of food that we take, but just by decreasing the portion size. Say for 7 days, you try to save 500 or reduce 500 kilocalories per day. This by just reducing the portion size or just by avoiding or decreasing one coffee, we can achieve it easily. So 500 into 7, 3,500 kilocalories. Then what we can do is we can indulge in a moderate physical activity, say a brisk walking for 30 minutes. A brisk walking for 30 minutes expends 350 kilocalories. If we do this brisk walking for 30 minutes for 3 days a week, we lose say 1,500 kilocalories. So, what we do now is we just require, when we have this 1050 kilocalories lost by exercise, now we have the luxury of increasing our food intake. Our calorie deficit by food can be decreased from 500 kilocalories to 350 kilocalories, because the additional 150 per day we get by moderate exercise for 3 days a week for 30 minutes. Next, what we can do is increase the time from say 3 days a week to 5 days a week. If we increase the time from 3 days a week to 5 days a week, we get more energy expenditure by that increased number of days of physical activity. Now, the calorie deficit will reduce from say 350 kilocalories to 250 kilocalories per day. So, initially we require to reduce our diet calorie intake by 500 kilocalories. It dropped down to 350 kilocalories when we walked for 30 minutes for 3 days. Then again it dropped by 250 kilocalories when we started walking for 30 minutes for 5 days a week. Then what we do is gradually we will increase our duration from 30 minutes to 60 minutes. We walk for 60 minutes a day for 5 days a week, then the 250 kilocalorie deficit also is lost. We can indulge in the original diet plan. We don't need to decrease our portion size also, provided we walk regularly for 60 minutes a day for 5 days a week. Then what we do is we will increase the intensity, say the speed of walking. Suppose we walk at the rate of 6 kilometers per hour, we increase from 6 kilometers to 8 kilometers per hour for 5 days a week for 60 minutes a day at the rate of 8 kilometers. We are more intense now. We are doing it for 5 days a week, and we are doing it for a prolonged duration of 60 minutes. Now, the total energy expenditure achieved by doing this exercise program is 3,850 kilocalories. Now, we have an allowance of excess 350 kilocalories, which divided by 7 any day we can take 50 calories more from what we are taking. So, we are allowed to take 1 idli more or 1 banana more, suppose we increase the intensity. Hope you understand that by just decreasing the portion size, we can decrease the calorie deficit. By increasing the activity, indulging in moderate activity for 3 days a week, we can decrease the calorie deficit. We can decrease it further by increasing the number of days from 3 to 5 days. We can make it nil. The total energy intake is equal to energy expenditure when you walk for 60 minutes for 5 days, and we can even exceed the intake when you increase the intensity of walking by 8 kilometers per hour from 6 kilometers per hour, sticking on to the duration of 60 minutes, 5 days a week. Now we have the allowance of having 1 idli more per day. Thank you. In this episode, I am going to explain what is the classic approach that is required to maintain the ideal body weight, how to prevent obesity in the most productive age group of 20 to 40 years. Our target is 20 to 40 years because in this age there is a chance for decrease in testosterone level and growth hormone levels. So the individuals tend to gain weight at the rate of 1 kilogram per year to a maximum of 14 kilograms in the case of male or 17 to 18 kilograms in the case of female. Also, the waist girth starts increasing by 1 centimeter per year up to 5 to 6 centimeters. There is a natural increase in waist circumference in the case of 20 to 40 years. By the year 40 years, the person would have gained 5 to 6 centimeters of waist circumference and would have gained a weight of 14 kilograms. This is a natural process due to lack of or decrease in level of anabolic hormones, testosterone and growth hormone. So we have to target this age group mainly, and this age group is the most productive age group. And if you are able to maintain the ideal body weight in this age group, then they will be disease free and productive for the rest of their lives, and the quality of life will be more in old age. They are protected from old age related skeletal-muscular disorders. Now, how to do this? Maintenance of ideal body weight. The classic approach includes both diet and exercise program. Both cannot be compromised. In 20 to 40-year-old, you cannot control weight by just restricting your diet without exercise, and you cannot control your weight just by doing exercise without controlling your diet. Both has to be regulated. You should restrict your diet and increase the activity also, which is called classic approach. How to do it structurally? As I said, start slowly. Our initial aim should be to reduce at the rate of 1 kilogram per week. First, as I said, start doing mild changes in your day-to-day routine. Try to reduce the portion size, avoid unnecessary snacking, avoid going to parties, avoid indulging in sugary beverages, avoid indulging in fast foods or packaged foods, avoid indulging in binge drinking, because alcohol is again most important cause for increased calorie load. Then you start moving. Start moving slowly in your day-to-day routine. Inculcate the habit of walking to school, walking to the office, trying to take the stairs, trying to use public transport more, try to go by bicycle. So inculcate in your lifestyle itself, which is called behavioral strategy. Then do it as a family. Don't do it alone. Educate the family, because the family cooking pattern, the family dining pattern should change. go together, walk together, eat together. Don't watch TV and eat, because indirectly you are likely to take more calories when you watch TV and eat. So sit as a family, eat as a family, move as a family, cook as a family, buy as a family. Then you will be conscious of what you buy for cooking, how you cook, what you cook, how much you eat. Then you walk together, you will have a systematic effect of exercise. So start with aerobic exercise. You start moderate intensity walking for 30 minutes, preferably outdoor. With the right technique, you go, especially in the morning, at least for 5 days a week. Perseverance is the key here, because fitness cannot be stored. You should continue to do that. Once you do that, you start getting the benefits. Once you start getting the benefits, you will have the motivation and you will be encouraged to be more aggressive. Now what you do is watch your diet carefully, get a diet plan, consult a dietitian. So bring in changes in your diet. Take complex carbohydrates more than refined carbohydrates. In the sense, watch your carbohydrate intake, increase your protein intake, try to take more of complex carbohydrate which are rich in fiber containing foods which have a low glycemic index. Try to take more of millets and sprouts, and try to increase the protein load by taking eggs, fish, meat, etc. in a moderate amount. So improve the quality of the food, eat intelligently, and in between you indulge in intermittent fasting also. Intermittent fasting benefits weight loss very much. Plus, more importantly, finish your dinner as early as possible. A dinner before 7 p.m. or 7:30 p.m. is ideal. Early dinner is the key first change required in your habit for a good weight loss program. Then coming to the exercise activity, I said start with moderate walking for 30 minutes. Then you can involve in other aerobic activities and even involve in anaerobic activities. Start cycling, start short sprints, short burst exercises of high intensity, say skipping for 5 minutes continuously. Initially it will be very difficult. Start with 30 seconds, go to 1 minute, then you can gradually reach that 5 minutes, or at least 2 minute skipping episodes. So like that, skipping is a very good exercise. Cycling is very good exercise. Then go for resistance training, which is very, very important. If it is affordable, join a gym, or else have the weights and do weight training. Weight training, the advantage is it's an anaerobic activity. Resistance training is an anaerobic activity. It builds the muscle. Once the muscle build is more, fat automatically decreases, fat content decreases. As I've already told you, 65% of energy consumed is maintaining the basal metabolic rate, and the basal metabolic rate is more in a muscular individual. So our aim is to build the lean mass, that is increased muscle and the skeletal mass, decrease the fat mass. The bone gets strengthened because of the weight bearing activity. Muscle buildup occurs because of resistance training. All these increases the basal metabolic rate, and just the silent energy consumption, even when you are quiet watching the TV, energy consumption keeps on going, which is called silent energy consumption. Thus, the optimal gain is achieved. So this is the classic approach of eating intelligently, right quantity complex carbohydrate, increasing the protein intake, persevering with your exercise program, combining aerobic with anaerobic, doing resistance training, weight training, and of course having a good quality of sleep adds on to that. Long live. Thank you.